Hi, my name is Miriam Alisfor. I'm an internal medicine resident at the University of Miami. Today, I'm presenting a meta-analysis examining the clinical outcomes of cancer patients with COVID-19. So SARS-CoV-2 has emerged as a global pandemic since early 2019 and continues to have a tremendous health burden worldwide. Cancer patients became of interest because of their immunocompromised state and initial data demonstrating that they are a high-risk population. Over the past year, starting from February, numerous studies have emerged describing the implications of COVID-19 on cancer patients. Initially, most of those studies emerged from China and had very small sample sizes. But in June and July, we started to see data emerge from North America and Europe. We noticed that there are large variations in case fatality rates, as well as other clinical outcomes, so we decided to pull such data. Similar meta-analyses were attempted by two other groups, but they either do not include new emerging data from US and Europe or do not report the range of effects or index of dispersion, which is important in this particular clinical question, as I will describe later in my talk. In terms of inclusion criteria, we included prospective and retrospective cohort studies, case controls, and case series which reported all-cause mortality and/or need for hospital admission or ICU admission and severe morbidity of patients with cancer versus patients without. Because of the rapidity of accumulated data during the current situation, we included both peer-reviewed and preprints for consideration. We excluded abstracts, cost-effectiveness, and letters to the editor. We systematically searched PubMed, medRxiv, JMIR, and Embase and retrieved all relevant English literature from January 1st up to July 8th, 2020. Two authors independently extracted data in a pre-specified coding sheet and cross-checked their findings. The quality of included studies was assessed using the Newcastle-Ottawa scale for case control and cohort studies. Now moving on to statistical analysis. Comprehensive meta-analysis version 3 software was used to obtain a pooled prevalence rate of cancer among patients with COVID-19. The effect sizes were expressed as prevalence rates with 95 confidence intervals. Prediction intervals were also calculated, which is an index of dispersion that shows how widely the true effect size varies using the same units of the effect size. This makes it a meaningful and clinically useful measure, especially in the setting of high heterogeneity. Heterogeneity among studies was analyzed using the I-squared statistic. Now, let's look at the results. Initial comprehensive search yielded 2,618 studies. After excluding duplicates and those that do not meet our inclusion criteria, we ended up with 34 studies. That brings the total sample size to 4,371 cancer patients with COVID-19. In terms of study quality, all the included studies had 5 out of 9 points or higher in the Newcastle-Ottawa scale, which we thought was pretty good. The outcomes analyzed include mortality, ICU admission, non-ICU admission, mild, moderate, and severe complications, ARDS, use of invasive ventilation, being clinically stable, and having clinically improved at the end of the follow-up period. We concluded that event rates for primary and secondary outcomes were associated with high levels of heterogeneity and broad ranges of prediction intervals. For example, mortality prevalence rate was 25.2% with a 95% confidence interval ranging between 21.1 and 29.7, and a prediction interval ranging between 9.8 and 51.1% with an I-squared of 85.4%. ICU admission prevalence rate was calculated at 11.9%, and being clinically stable prevalence rate was 25.2%. What was clear from the prediction intervals for all the outcomes analyzed is that the outcome prevalence rates were highly variable between individual studies, and so the pooled estimate is not reliable clinically, which prior published meta-analyses failed to account for. Despite the variability, the mortality rate in cancer patients with COVID-19, even at the lower end of the prediction interval, which was around 9.8%, is higher than the mortality rate recorded in the general population with COVID-19, which is around 2%. Such variability may suggest that the measured outcomes are affected by variables that have not been taken into account, such as viral load, cancer type or stage, cancer treatment type or duration, etc. Publication bias was not examined nor adjusted for in this study, since the concept that statistically significant studies are more likely to be published than non-statistically significant ones does not apply to prevalence studies. Finally, we recommend that prevalence rates of outcomes, such as mortality rates in cancer patients with COVID-19, published in prior meta-analyses, be examined with caution when deciding management protocols for such a population amid this pandemic. And further studies are needed to examine cancer patients with COVID-19 more closely by accounting for variables such as viral load, genomics, comorbidities, and cancer treatments. Thank you for listening.